Hi, okay, so we have a nice gentleman with an exposure keratoconjunctivitis of the left eye. He's had a hemifacial paralysis. He's been told by other providers that his eye is dry, which loosely is true. His eye is dry, but it's not only dry. It's dry because it can't close. It can't close, he can't blink, and it's pretty open all the time. He uses lubricant drops here and there. He also uses IOP drops, as you know. Essentially, all the glaucoma drops, you put them on the surface of the eye, they penetrate transcorneally, causing some epithelial disruption on the way in. Preservatives can collect on the surface, increasing tear film osmolarity, exacerbating ocular surface dryness over time. So that's kind of where we're starting. We can put him on more intense lubricants and this and that and immunomodulatory drops and nighttime ointments, but the nighttime ointments might conflict with his nighttime IOP drops. So there's some stuff there. Plus the timeline for all that's very drawn out, right? Because the causative factor is still there. His eye doesn't close. So what we're going to do is we're going to do an amniotic graft on the right eye. And in doing so, we're going to use an Aurora graft that has the central aperture, 5mm central aperture, so we can still see. We're going to apply a bandage lens on top, and we're going to leave him like that for a couple of days. We'll bring him back in about 2 days and take the lens off. To get a quick idea of what his eye looks like right now, let's go ahead and take a quick look through the microscope. Come this way, sir. So if we look through the microscope, this is basically what you expect an exposure keratoconjunctivitis to look like. The lower half of the cornea, he's got diffuse staining there. Some of it's starting to coalesce, and you're getting kind of just small aggregates of epithelial loss and microerosive defects. As you can see, some areas stain more brightly than others. Some areas have a bit of hazy stain around them, and that shows you that the epithelium is loosely attached and you have stains seeping underneath. So his stage is kind of set to worsen here. Here we go. We're draining out most of the fluid from what would be the bandage lens so that we're not going to introduce too much fluid to a membrane that's trying to adhere and destabilize a graft that's trying to adhere onto the ocular surface. Here's our Aurora graft. Is that clear there? Mm-hmm. Okay, you can see it's a 10mm in total diameter, 5mm central aperture. You want to come nice and close? Mira aquí a mi ojo. We want to try, now normally when you do an amniotic graft, you use the limbus as a reference point. Here we're using the pupil as a reference point and trying to censor it well over the pupil. As you can see, if you go close, you can see good. Now we're just smoothing out. Of course, the geometry changes a bit. You're putting a two-dimensional flat circle on a three-dimensional curved surface. There will be some folds, but they're not so bad. Our pupil's well centered. He's okay. And bandage lens going on. Sorry guys. Bandage lens going on. I got in the way there, but bandage lens is on. Mira abajo el piso. Mira a mí. Good. Suavecito, cierre, abre. Mira aquí a mí. Good. Y cierre el ojo. Trata de cerrar el ojo. Déjalo cerrado. Good. Very easy, and that's with explaining and taking time and all that. If we were to do it more fluidly without this video component, probably 10 seconds to place. Very easy. Let's take a look through the microscope one more time and see what it looks like. Abre el ojo. Come. Good. In short, the graft is on. There's an air bubble. There's an air bubble in that lower left corner, inferonasally. Not a big deal. Just with eye movement and blinking, it'll come out. But you can see the graft is on. The pupillary part is centered over the pupil. In short, it's a good placement. The risk of a hypoxic event happening. We're using a lens that allows him about as much, a high DK contact lens, about as much oxygen as if he had no lens on. And if he doesn't, we're also going to give him lubricant drops that would support the exchange of oxygen and fluid underneath the contact lens to, again, lower the risk of a hypoxic event. We're also going to give him either Tobradex or Maxitrol drops to use. The antibiotic component will help to keep the proliferation of most of the common ocular surface bacteria in check for the duration of treatment, which for him is going to be just a few days. And the dexamethasone component will help to safely offset hypoxic sequelae like corneal edema, infiltration, ulceration, anterior chamber reaction, conjunctival chemosis, injection. All that stuff will be safely and effectively offset for the duration of treatment as well. And then we'll see him back in a couple of days for part 2. All right, so you can see here's our friend with exposure keratoconjunctivitis. You can see by the way he blinks that he does indeed have a chronic lag ophthalmos. But the quick answer is look at his cornea, look at the staining pattern. Abre el ojo, good. He looks great compared to just 2 days ago. So we very quickly optimized the surface integrity of the corneal epithelium, as well as improved tear film stability, improved symptoms associated with the ocular surface dryness, and also he's going to notice that the clarity and consistency of his vision, the clarity of his vision and the consistency of his clear vision is improved as well. So in short, good, safe outcome in record time. Thank you.